important that we just crack on. That's the transcription started again, so I think we'll just move on with the next item, and the next item is the IPQR dashboard report, which is a report by Rhiannon Boydell. Rhiannon.
Thank you very much, Chair. So this is the performance framework for the health and social care elements of the annual delivery plan. I'm going to just go through some headlines. You've actually had a good discussion about some of these headlines already. So the headlines within the report are that for care at home, we've got relatively unchanging levels of unmet need related to care at home availability and capacity. We've had a combined reduction in a continued reduction in independent sector provision related to workforce issues, and it's a picture of an ongoing pressured environment. The care home picture is similar, and you've had that discussion already, so I won't delay on that and linger on that. In terms of DDs, again, the pressures within the system shows a relatively static position over the last 6 months following a rise over the summer. With carer breaks, the number of approvals are fluctuating month by month. There isn't a specific trend I can see there. With SDS, we've got a continued rise in the option 1 direct payments, especially in our remote and rural areas, related to some degree to there being a lack of availability of other services in the area, other ways of doing it. And our ISF option 2 is continuing to reduce. In terms of adult protection, there's a continued rise in referrals, although March figure is slightly lower there, or is certainly the lowest in the last 3 months. With psychological therapies, we've got a significant reduction in long waits. That's a nice looking graph there, and it shows us achieving 86.7 versus the 90% target for people waiting no longer than 18 weeks. So we're showing improvements in both the long waits and the shorter waits, so improvements in the 18-week target. And in terms of drug and alcohol recovery, again, we're showing 87.8% against the Scotland 91.1 performance against standard for completed waits. So the target's 90%, but again, that is an improved position. And on the non-reportables, just a note, which is already in there, just to draw your attention to the caveat about the accuracy of the data there, and there's some work that we need to do around that and with services. And that was it. So open to questions, whether it be from myself or the service leads.
Well, thanks very much, Rhiannon. That was a very quick roundup of the key points in the report. So do we have any members of the committee who've got questions for Rhiannon? Yes, Anne.
Maybe a couple of questions, Philip. I was wondering whether we are able to produce data on the length of waits for care at home clients. Obviously, we have data here about how many have been assessed as needing care at home and are waiting. Just from a quality perspective, I suppose, a system impacts perspective, I just wondered if we have data on the length of wait and whether that could be included in the IPQR in the future.
Sorry, Anne, sorry.
No, well, it's okay. Do you want to come back on that first?
I can certainly look into that. So what we've got here is our reportable data. It's the data that we report on. I'm not sure whether we would have the data stored, if you like, as something that's immediately available to a data analyst, or whether it was something that would need to be produced by hand by the teams. But I can certainly take that away and find out, Anne.
I mean, okay, that's great. I don't know whether Simon or Pam would like to comment on whether that would be a useful or thing to include in the IPQR in the future.
Yes, I can comment absolutely, Anne. And we had a really good session at the board development session yesterday, looking at the IPQR and performance. So we'll definitely be taking forward some development work in that area, and importantly in terms of our Highland partnership, working with our joint officer group and joint monitoring committee colleagues. I'm sure they would find that information good to see as well.
Okay, thanks. And the other thing you commented on the improvement in performance, Rhiannon, for psychological therapies, which is obviously good to see. However, there are still quite a lot of people waiting for those treatments, and I know from other papers that there's a very detailed improvement plan in place. So I just wondered whether it would be possible to include in the narrative perhaps the next milestones of the trajectory for improvement, so that we could monitor whether we're keeping to our improvement trajectory or not in relation to these particular therapies. Happy for that to be taken away and discussed with others. But we've some of the committee will be aware that we've recently had a governance self-assessment, and a lot of the discussion was around needing to focus more of our performance scrutiny on forward-looking aspects and on trajectories, and whether or not the improvement actions are bearing fruit. So that's really the background to my question on that point. But obviously good to see that improvement taking place. Thanks.
Thanks for that, Dan. So if there's no further comment from either Pam or Rhiannon there, we'll move to Michael. Have you a question?
Yeah, I just want it to be my total misunderstanding of this, but why does this exclude Raigmore? This is the very last paper, very last page on this paper. Is there a reason for that?
Shall I come in?
Yes, Rhiannon.
Yeah, so my understanding this relates to services that the Health and Social Care Partnership delivers.
Right. Okay. So an appointment at Raigmore is excluded because of that. Is that what I understand? I don't really understand. I understand the point you're making, but to me, a service is a service, whether it's at Raigmore, Migdale, or somewhere else.
Sorry, Philip, could I just come in here a minute? So and that's because I raised a question about this at the last board meeting. So this information, Michael, as I understand it, relates to services that we do not regularly report on our performance on these services to government. That's why it's described as non-reporting. And because for this committee, that obviously applies or the information presented here is in relation to services that the committee is responsible for, which is just the community directorate and doesn't include Raigmore. So that's why Raigmore is not on this particular report. However, I did ask at the last board meeting whether there was a similar list of services for our acute services that we're not obliged to report, to government, but that it may be useful for the board to be aware of the performance of, or at least waiting times for. So I'm not sure what the response will be on that, but in terms of this report, it's just because Raigmore is not part of our responsibilities.
I understand that, and the reason I mentioned is that I'm waiting for consultation in the department of Raigmore. I've been waiting for 8 months, and so what I'm also interested in is why are all these put in weeks? because if I'm waiting for 8 months, according to this, it'd be 32 weeks. Now, 52 weeks is a year. I don't understand the week thing. Why is it, when you get to a year, why is it not a year and then it goes on from there? Why is the reason that all these are set out in weeks?
Do we have anyone that can give us comment on that? Pam?
Thanks, Philip. I was just going to come in just in an answer to Michael and to Anne. Maybe we do need to think about our hosted service. So, for example, if someone was was waiting for an appointment for the pain management clinic, for example, we may want to reflect more of our hosted services within the community at this committee. Michael, in terms of weeks, it'll be around the national reporting. And perhaps Tim may be able to clarify some aspects around the public health measures and the reasons why we report in that way. But also in terms of weights, they are considered in weeks in terms of 18 weeks, for example, for certain standards. So, but we can look at that and modify the report going forward. We'll take that back to the performance group and have a think about it.
I'm sorry, just it was purely a lay question. It wasn't professional. It's purely from a lay person's point of view. It doesn't sort of be logical sort of thing,
No, absolutely, and we have to make sure that our information is framed in a way that people understand it, and that it actually reflects a level of how people can engage with that information. So your question's absolutely welcomed and absolutely valid. Tim, do you want to come in?
Yeah, just quickly to follow up on that. I think it also reflects a desirability of to have waiting lists measured in weeks rather than anything longer, because we really don't want to wait that long. Like probably many people here, I'm on the Regmore waiting list, so it does affect a lot of people, and I think it's simply that it was set up as weeks in order to give a to give a sense of comparability of how long people are waiting, and because it's got so long, sadly, in many cases, it makes it a little less relevant. But it's simply, I think, to get some measure of comparability.
Thanks for that, Tim and Pam, and hopefully that. That'll answer your questions there, Michael. If we could just go back to the first part of your question about the exclusion of Regmore. Clearly, Anne has noticed this as not so much an omission in our stats, but it's something that our stats don't cover. Did I pick up that you were going to investigate that, Pam, and see what was available for the future?
Yeah, I think, well, Rhiannon leads this up with David Parker, our Deputy Chief Executive. I guess we may be interested in some sort of triangulated data. So, for example, if we had a problem with flow because people were waiting for care within hospitals and that was affecting elective waiting lists, that may be of interest to this committee in terms of assurance about the actions that were taken around moving people through the system, for example. So we can certainly go back and look at that. And one of the aspects that we were thinking about at the board development session yesterday was exactly that. I was actually sitting in the performance working group that we had during the session, and we were looking at the triangulated data requirements. So that might be something for a development focus going forward. So I'll bring that back. Rhiannon and I will bring that back to the department, and we'll feed that back in on behalf of the work that we did at the board development session yesterday as well.
That's much appreciated. Thanks very much for that. And going back to the committee, if there are no further questions, we've been asked to give moderate assurance or receive moderate assurance from this. Are we quite content with that? Yes, nods. Thanks very much. And we'll now move on to the Chief Officer's report from Pam. Thank you.
Okay, thank you. I'll just get onto my screen again and pull up my report. So in terms of, sorry, I just checked, I'm on my one screen, I've got my microphone on. Okay, hold on just a sec. So in terms of the Chief Officer report, I've brought back the project updates from North Skye Healthcare, the Lochaber redesign, and the Caithness redesign as well in the North Hub. So we have appointed Balfour Beatty. They've been confirmed as our principal supply chain partners for the Lochaber and Caithness redesigns. There was a cross-check event held just recently in Fort William. So I went down to Fort William. Really good to be local in the locality with people, looking at the principally in that session was about the new hospital build in Lochaber. But I was presenting and so were a few colleagues around the community inputs and how we want to develop the community and how that should be seen in the context of the hospital redesign. So community aspects perhaps considered late to the party because they have focused on a bed base first, but I really felt that we had the ability to influence and co-produce as a result of that cross-checking event. So that was really positive. And of course we've already had the cross-check event up in the north, which we referenced earlier, and there's another event taking place early in May again. So going at pace now to engage with the community and with the staff in terms of building on those models and taking forward those redesigns. So that's really good. In terms of the care home oversight aspect, I did mention a bit of this when I gave the care home report earlier, talking about the changes that are forthcoming to the care homes oversight group and moving us into the sort of approach that we work in a collaborative way to ensure enhanced clinical and care support to the care homes going forward. And I mentioned some of the funding that had been received that we've outlined here as well. So as I mentioned earlier, we'll bring a full report of the work of the current care home oversight group to the next meeting as with our agenda planning and how the timelines fall. So I'm happy to take any questions, and obviously in the meeting we've generated a number of subjects for next time's Chief Officer report. Thank you.
Yeah, thanks for that, Pam. It's covered some of the previous conversations that we were having within the committee. So do you have any questions from any of the committee members for Pam? Anne?
So, Pam, that I was pleased to hear that you had an opportunity at the Lochaber cross-check event to raise some of the potential opportunities in relation to integration of the community and hospital redesign.
Yeah.
That's a query that I would have been asking a question about that if you hadn't, brought it up yourself. And I just wondered, particularly as we have Neil with us on the committee, whether you could say just a little bit more about what you see as the opportunities to, further develop the redesign and the integration between community and hospital services. I'd be particularly interested, obviously, to hear what Neil's thoughts are on what you've got to say. Thanks.
Sorry, Neil, are you going to come in there?
Yeah.
Thank you.
I was going to say the first thing is, unfortunately, I feel slightly embarrassed that this cross-check flew completely under my radar, so I'm not quite sure how it was advertised.
Okay.
I feel a little bit like Michael, somewhat left out of the loop. So I'm interested to hear what you have to say. We had an interesting discussion at Cluster with people who are directly involved in the hospital rebuild, and obviously there's been a lot of focus in Lochaber around the hospital rebuild, and I and a few others have also tried to push actually more for integration and sort of if you like, a focus or even a step back to look at service redesign rather than just purely hospital. Otherwise, we tend to find you get a lot of loud voices looking for things which are A, possibly not easily deliverable, B, not necessarily required, but may take the focus away from more of, if you like, community care development. Having said that, I'm also of a mind, not sitting on the fence, but sitting on both sides of the fence, that hospitals are required, and they're there for a reason, and sometimes we have to go to them. So we do need hospitals, but we unfortunately also, despite the resource implications, we also need, given the changing demographic, more community resource. So yeah, interested to hear what went down on the 18th.
Okay, I guess I need to take back the points that raised by yourself and Michael about engagement and about awareness of the event, and I'll need to take that back to the local areas in terms of the project team. There's a cast of a lot of people involved, and obviously we're not actually getting to everybody in terms of invites and engagement. So I'll definitely take back both of those aspects for the North. And case design and Lochaber. Okay.
Sorry to interrupt. Are there forthcoming events there? Because that sounds like something we need to do quite sharpish, just to ensure that we don't miss some relevant people. And I would have thought some members of this committee are reasonably high profile and who we need to reach for that.
Yes, so there is another cross-check follow-up event up in the North. It's being held in Wick. I think the 11th of May might be in my head for some other reasons. I would just have to check my diary on the absolute detail. But there is one early in May. So that's taken place there. We've also got a number of groups set up around some of the community work streams, Neil, so I'll make sure that you're linked into them, and that Kate Earnshaw links you in with them, and we'll take forward. And I need to acknowledge that people have been missed out in terms of our engagement and communication, and address that. But yes, I did mention, Anne, that we were late to the party in terms of having the agreement for a hospital build, and it was very much a focused event on what the hospital would be providing. But I was invited. I was invited to give a presentation as part of the cross-check. So did Jo McVeigh, our Director of Allied Health Professionals. She was also giving a presentation. And the value of having the cross-check event is that the way that it's set up, you've got a kind of table down one side of the wall of the presenters, and then you've got down the other side of the wall the kind of cross-checkers, the people who will ask you questions and seek out and search and bring up issues that perhaps we've missed out, or things that need to be clarified or addressed. And then through audience participation and writing up the notes, it keeps us in a frame of continuous dialogue, notwithstanding not everybody's been engaged. So I'll address that going forward. But thanks for your question, Anne.
Yeah, thanks for that response, Pam. And it would be good if we can ensure that there are any gaps there that are filled. Any other questions from the committee? No, that's fine. In which case, we'll move on to the next agenda item, which is the adult social care fees and charges. And that's a report by Colin Stewart.
Thanks. Colin's going to present the report. Thanks, Colin.
Thank you very much. Hopefully everybody's managed to have a chance to review the paper, but I'll just go through first for you. So this is the fees and charges report related to adult social care, and these are the few recommendations that we put forward based on work that was undertaken with the fee briefing group, and these were subsequently endorsed by the Chief Officer and the Director of Finance. In terms of the background, the due process has been followed, whereby the fees group were presented with recommendations which were subsequently reviewed over a number of meetings. The approach that we've adopted follows the Scottish Government approach, where for registered care services, we're looking to uplift to be able to fund the Scottish living wage, which is now £10.90, and that's the minimum payment for staff delivering care. It covers all the registered services from care homes to care at home, support, housing support, and covers the wide range of services that we look after. Approximately £121 million worth of spend, and very much we've as I say, we've followed the Scottish Government policy, and of particular note this year is National Care Home Contract, which is a contract we've adopted for a number of years. Unfortunately, this year the National Care Home Contract is not settled, and there's still ongoing discussions between Scotland Excel, COSLA and Scottish Care regarding this. Within the report, there's a requesting to make an interim uplift, and this follows the recommendation from COSLA, and that's just enough to provide the living wage payment to care homes. In terms of the other uplifts we're proposing, it's to the 1090, and we're looking at a year's extension to the contract, which is in line with our normal due process. The measures proposed will cost approximately 3.497 million. That includes the implementation of the interim payment for the NCHC. I think I've explained the route to the meeting, and there are a number of recommendations that we're bringing forward to you today. The first three are around awareness, that we followed the Scottish Government COSLA approach. The recommendations have been prepared by the fees group and endorsed by Chief Officer and Director of Finance, and for awareness that the National Care Home Contract is an interim settlement. And in furtherance of our due process, we'd ask you to consider and agree the recommendations that are included at Appendix 2 within the report, which I'm obviously happy to go through if you wish.
I think the appendices are there for all the committee members to have read, and I assume that we have. So thanks for that, Colin. Do we have any questions from any committee members? I was wondering, because this is something that we see quite often, or we have in the past, that the national negotiations go on, and they're not agreed at this time. Have there been any occasion when it's not been agreed in the past?
No, it's come close, and there's been times when several authorities have looked to leave, but they didn't. This year it is different. The care homes have rejected the offer. There's been two offers made by COSLA, and they've both been rejected.
What's the risk that this won't be agreed, bearing in mind we've got the roll forward until the 30th of June?
It's fairly high. The care homes have asked for a large uplift.
Yeah.
The uplift proposed by COSLA didn't come close, and there's an impasse at the moment, but we're still awaiting an update from colleagues in COSLA as to what the next step is. Okay,
and in terms of that impasse, if that isn't agreed by the 30th of June, what kind of actions are we proposing to take, or do we have a plan B, as it were?
Well, there's been obviously that we're aware that this could very much be the situation, and there has been some discussion internally behind the scenes, and there has been a request to our colleagues in the council to seek an update from COSLA regarding this.
Thanks for that. I noticed Simon's hand's up there, so do you wish to come in here, Simon?
I thought it might be helpful if I came in, Chair. There's a couple of significant considerations here. The first, of course, is that when it comes to the actual negotiation with Scottish Care involving Scotland Excel, COSLA, etc., that's a negotiation that's undertaken by the council, and then the results of that negotiation is usually reflected within the way that the quantum is calculated in terms of the delegated statutory functions that we undertake on behalf of the council. So it's not really, if you like, our negotiation. We're dealing with the results of it. The second, to make sure that the committee is cited on the Highland position, is that we operate to the National Care Home contract because it provides us with a stable basis upon which to negotiate with the independent sector care homes. Were the contract to fall in Highland, I would expect to see us having to undertake individual negotiations with individual care homes, and that would give us absolutely no firm foundation, and we would probably end up with a degree of inflation of cost that would be tied to that. The final bit of this is that it's a very complicated series of costs that are taken into account that relate partially to pay, but it's effectively an algorithm that is being operated through the Scottish Government, and we have to take into account that the setting of, for example, a particular pay rate. So say the pay rate set at say £10.90, or say the pay rate set at £12, then that tends to have an impact on the algorithm, but the algorithm doesn't then take into account things like differentials. So there's then a further series of cost pressures that might well hit the sector. So the key things for the committee to be aware of, I would suggest, in terms of where we're at with the negotiation and where you cannot take assurance at this point, is firstly that the negotiation effectively sits with the council, and Pam Crown, the chief officer, has asked the chief social work officer for a formal update on the position at a joint officer group meeting, which will take place at 9 o'clock on Friday. The second issue that we need to take into account is that our current financial forecasts and financial position is entirely predicated on the assumption that we have a national care home contract. And so therefore, were we to find ourselves either with a change in rate that wasn't funded, or alternatively a loss of the contract, we would have to be coming back to this committee with a changed financial position. And then the final point of this is that we as a partnership have to remain concerned that if the sector is saying that the national care home contract will not operate satisfactorily at the level being offered by Scotland Excel and the Scottish Government, and that is the final offer, then there is the potential for an already destabilised system to destabilise further. So if you take all of those into the round as a committee, I don't think you can take assurance in relation to the national care home contract, because there are basically far too many unknown variables at the present time. I'm sorry I can't give you better information than that. I'm not sure, Chair, and I would have to be guided by yourselves about quite how we then report in on this very fluid situation, because we will hear at some point, but we cannot even give you a date as to when the negotiations will be concluded by.
Okay, thanks for that. That doesn't paint a very pretty picture at all. There's a couple of things there, or a few things there. The first is, on practical terms, if they aren't negotiated, the national contracts aren't negotiated by the 30th of June, when we have extended ours, are we in a position for those to be extended once again? Does anybody know the answer to that? Simon?
We can continue to try to extend based on the extant agreement.
Yeah.
Our problem will be whether or not the sector would agree to comply with that. That's the kind of I suppose effectively the knife edge we're on at the moment is and at the present time the question is whether the contract is going to be fully renegotiated or whether an interim arrangement can be found which would allow us to get to the final negotiation, if you get what I mean. So the hope at the moment is that there'll be an interim arrangement until June, and then we should end up with a firm, more root and branch review. That's where the sector are wanting to get to anyway, I think.
Okay.
So the answer is yes, we could try and continue it, but what I can't answer for you is how the sector would respond to that. Okay.
And is there any other mitigation we can put in place for developing a plan should anything untoward happen?
The principal mitigations we've got are speaking pretty well weekly to the sector and sector representatives and keeping on top of this as much as we can. We've got some very good communication links with them. There are no real mitigations that can actually be offered, because we then get into a question if we're running at almost 100% of capacity in Highland, which is kind of pretty well where we are, then if providers are saying they would walk away from a contract on the basis that it wasn't sufficient, and they would be giving us notice, then we're into a situation where we don't have alternative capacity.
Okay, thanks very much. That's quite a stark picture that's painted there. Any issues that any other committee members would like to contribute with? No. Okay, in terms of what we've been asked, we've got 4 recommendations. 3 of them are for noting, with the 4th to consider and agree each of the fee and contract recommendations at Appendix 2. Is the committee happy to note the first 3 and agree number 4? Yes, okay. I have nods and thumbs up there. The second part of what we need to do as a committee is clearly take assurance from that report. And as Simon said, we can take no assurance based on the fact that the national contract position is quite as fragile as it is. I wonder if we can take assurance from the process in terms of the way that we've applied the process, and that the process is continuing, and Simon's given us the assurances of weekly contact and weekly meetings. So can I suggest that we take at least a moderate assurance from the fact that the process is in place, if not the result that we're currently awaiting for? Is that a reasonable suggestion? Michael, you would like to come in?
Isn't it a more limited assurance than moderate?
Quite happy to consider that. Is the committee more persuaded that we should have a limited assurance? Pam?
Well, I guess as has been described in the debate about the contents of the paper, you know, there are aspects that are out with our control, but that we're absolutely engaged in through the partnership. You know, moderate assurance is applied in the paper in terms of the processes that we have within the partnership to actually deliver on this, to actually reach our conclusions, to apply the fees as we have them given to us and guided by the Scottish Government. So we're meeting all of the legislation, we're meeting all of the aspects. So I am reflecting that this is a very robust paper. The route to the meeting has been very robust. There's several different committees and groups in place where levels of scrutiny are already applied. So I would be hoping that the committee would be agreeing the substantial assurance as proposed in the paper on that basis.
Simon, did you want to come back in there?
It was just to work with where Pam is at on this one. The point I'm providing to the committee is there are some things you cannot control as a committee at the moment, and the national negotiation of the National Care Home contract is not something you can control. So therefore, you can't take assurance around the outcome of the National Care Home contract negotiation. And with Pam, I think you can take assurance that we are doing everything that can be done, and in a robust fashion, around our contributions, oversight, and any mitigations we can see that we can put in place around the National Care Home contract. But the final outcome of the National Care Home contract will be without, or will be out with our actual individual control.
Anne.
Perhaps we could just recognise that in the minute, Philip. So for it to read something like the committee agreed to take substantial assurance other than on the outcome of the NHCH rate, just as, you know, something like that.
Okay, that sounds reasonable. I think we have done as an organisation as much as we can. The outcome isn't within our gift, and I think that we can say that we can do no more. So we are kind of waiting, if you like. So yes, if we can have the minute reflect, if the committee is content with the minute reflecting, in the words of Anne, that we take substantial assurance in the process, but we have got limited, or we have got no control over the outcome. Is the committee content to proceed on that basis? Yep, nods and thumbs up. So thanks very much. We'll watch the outcome of this with bated breath, and hopefully there'll be some quick resolution to that, but we shall see. Thanks very much, folks. And we'll move on to the next part of the agenda. We've got district reports which are postponed until the next meeting. So it takes us on to the committee work plan. So the committee work plan is as in our papers, but I think with some of the reports that we've already discussed, we need to bring some more reports back to the June meeting. And the June meeting looks already quite a busy meeting, so I think I'll sit with Stephen. I don't have a record of all the papers that we're due to come back to. I'll sit with Stephen and perhaps look at the work plan and the agenda for the next meeting, and we might have to do something about moving some of these reports to other meetings. Although we don't want to cause an impact for the future, but there does seem to be quite a substantial agenda already for the next meeting, with some of the reports that we have to take back owing to the position of the assurance that we've received today. Simon.
Yeah, thanks, Chair. I don't want to increase your troubles. I'm just conscious that at the previous committee, we were asked for comment in relation to self-directed support and rates that we're proposing in relation to personal assistance and the approach around that. So that's a further item that I suggested might need to come forward in June. The other one that I'm also conscious of that wouldn't be in there at the moment would be around the cost containment plans that we would have around adult social care, which I suspect would need to have some kind of report going to that committee as well. So that starts to take us into some pretty other big meaty items as well. So my apologies, Chair, but I couldn't leave them on the floor.
No, we need to take cognizance of all of these things, and it may need a bit longer meeting than our usual. But I'll have a look at what we have to have. Pam, that's a discussion you, Stephen, and I can have if there's no sign of Jerry back.
Absolutely, and we need to extend an invite to the Adult Protection Committee for them to provide the annual report of their works, which wouldn't normally be authored by Stephen. And we've also got the Chief Social Worker's annual report coming. I'm just conscious that we've got a couple of other things next month. One is, a big issue around, and I think it'll be a big paper, will be the dental position update. And in terms of, we are making good progress against some of our trajectories in terms of delivering the drug and alcohol recovery services. We've done significant work around the MAT standards. I wondered if we could postpone that paper. We've got a new service lead coming in, and we would want to give her time to actually, do the report with support from Arlene, and ask her to come to the committee in July with that paper, which would introduce her nicely and give her a bit of a time to get in a state of readiness. So if we could meet with Stephen then and do some agenda planning, I think that would be good.
Sorry, that last paper that you mentioned, what was it?
It was the drug and alcohol recovery services delivery plans.
Yes.
So we've got a new manager, we've got a new leader coming into the service, and to allow her just to get up to speed. And of course, you can accept the students earlier from the IPQR. You can see that the positive progress that we're making, and it'll just give her a bit time to frame in as well the medically assisted treatment standards, so that we get a more robust report coming next time, time after, if that would be okay. But you and I and Stephen can pick that up in terms of our agenda planning.
Yeah, that sounds sensible, and if the committee's content, we'll take that away and we'll meet separately, and we'll revamp the agenda as it's required. Okay, so moving on to the next agenda item, we have risk, and the report by Jill Mitchell.
Thanks, Chair. I'll just pull out some headlines from the report. So the report is for assurance. Section 2.2 gives some of the background around the structure that we have in place. There's been quite a considerable amount of work around risk registers over the last 6-12 months. A lot that were paper format have now been transferred onto our DATIC system and are much more visible. So within the Directorate, the operational units, the divisions, all have their own individual risk registers. There's monthly meetings in place where all of those divisional risks are discussed and refreshed and updated, and ensuring that there's mitigating actions and plans associated with all of them. Once a month that we all come together across the Directorate, and we talk about new risks that have been added to the risk registers, any that have escalated in terms of their status and their scoring, and we also agree anything that needs to be escalated, whether that's up to senior leadership team, through care and clinical governance, the Health and Safety Committee, or in fact this committee, or Executive Directors Group. So section 2.3 goes into a bit of the detail. At the moment there are 47 risks recorded on DATICs at level 2 and level 3. These are the levels that are reported through our DATIC system. This section contains some of the detail, but we've not included all of the detail in relation to all of the risks. It's kind of themed. There's obviously from the level 2 very high risk, we've got dental position, and obviously John Lyon, our Director of Dentistry, is coming along to next meeting to give a more comprehensive update to the group. We've talked about the care home sustainability and the sustainability of small care homes in previous papers. Just a few others I'll pull out. We've obviously talked about mental health and learning LD today, and we've also got some issues around primary care, obviously the sustainability of current practices, recruitment in some of our board managed practices, and high locum usage as well. So again, I'm not going to go into the detail. There's some themes at the end of section 2.3. Availability of workforce we've touched on in some of our earlier reports. Remote and rural areas remain a significant area of concern in relation to recruitment, and that's across all disciplines. It's not any one staff grouping. Statutory and mandatory training, we've done quite a bit of work on that. We have an improving position that's been reported through staff governance, but it's very much work in progress, and we continue to have a focus on our compliance rates across the division. Financial risk, again, we've talked about earlier in terms of the cost saving plans that need to be put in place for the next financial year, and obviously, you know, our delivery plans around that that, which will become more detailed in the next couple of months. We've mentioned the sustainability of the smaller care homes. There's also something to note there around our system pressures. Traditionally we would have winter pressures within our system, but we've seen those significant pressures continue into spring, and winter pressures remain at levels where we've escalated. We're doing some work as a division to look at how we report our operational pressures through a system which is called OPAL, and we can come back and discuss that at a future meeting. We do also have premises and accommodation risks. We've talked about some of the redesign projects that are in progress, but we do have some specific issues with our existing premises, sometimes where there's been a backlog of maintenance or ageing estate that requires capital investment. There's a specific improvement plan in place around ligature risks, and Arlene's leading on that work. And then again, we've highlighted the lack of availability of lower medium secure beds across Scotland from mental health perspective. So I think I'm just going to pause there and take any questions that anybody wants to highlight.
Any questions from around the committee? Anne.
Thanks, Jill. And can I just say that I was pleased to see that you're considering the introduction of a community version of OPAL, because we've had very good feedback to the board on the introduction of that in our acute services. It seems to have been very well received. So that's very interesting to hear that. But I just wondered whether you might not be at this stage yet, whether that would be in relation just to NHS Highland Community Services, or whether it might be trying to encompass independent practitioners, whether that be GP, pharmacy, or whatever. But certainly it's encouraging to see that we're looking at that. The one thing that I was a bit would like to hear a little bit more about, there was quite a number of references and different aspects regarding the out of hours service on this list. So given our earlier remarks, I'm not going to ask for a report to the next meeting, but I wonder if you could just say a little bit more about, overall where you feel that risk sits, and a little bit more about the mitigations and how effective they're being at the moment on that specific area. Thank you.
Yeah, no problem. I'm happy to come back in on those points. So yeah, community OPAL, we're developing a version for both community and also Arlene's leading a piece of work for mental health. And then what we'll do is have the conversation about where we integrate these approaches. So we've got a system, OPAL reporting system. We do have a daily dashboard, which is in place at the moment in community. It's not visible, but that's going to form the basis of how we take forward OPAL. We do include as much as possible a detailed report, so people will report in where we've got pressures, whether that's in community pharmacy, optometry, dentistry, and also general practice as well. So we will include that, and we'll do a bit of focus work around what we do for the independent care sector and how that's recorded and captured in our community OPAL. So it's very much work in development. We're really hoping to get something up and running, test it over the summer in preparedness for going into next winter. In relation to your second point, Anne, which was around out of hours, we've been involved in a specific piece of work over the last 12 months to look at out of hours in a bit more detail. So there's quite a lot of work which we've done. One of the things we were keen to do was actually get a risk register established for our out of hours service. We're actually looking at the governance structure that sits around that at the moment in terms of what's the assurance group that supports the out of hours service, and also what's the operational plans for implementing some of the improvements that we've identified over the last 12 months worth of work. I think it was noted earlier on in the meeting that there was a piece of work that was done in B&S that yielded some savings in the out of hours service, and that was because there was a skill mix. And part of the issues that we've highlighted in the out of hours services, where we've got a shortage of GPs in a sessional capacity to work in hours, or salaried GPs to work in an out of hours setting, we are going to have to look at alternative skill mixes and models of provision. So in some areas in Skye, we've got a rural support team. But what we need to do is look at where are our senior decision makers and our GPs in any of the redesigned models. So out of hours and the redesign work is an ongoing programme of work. I'm currently taking the lead on that within the organisation. We're looking at where we can centralise. We've had a devolved model in the districts, and we're looking at where we can have that organisational overview and work smarter in terms of service and make it more sustainable for the future. So quite a bit of detailed work ongoing, and more than happy to give an update in relation to future meetings, but obviously not the next one.
Yeah, thanks for that, Jill. We've got a further question from Muriel.
Thanks very much for that, Jill. There is a lot of great work going on. And the rural support teams, is that including the paramedics as well, or the, excuse my old head using old language and terminology?
No, you're absolutely right. I think predominantly it's advanced nurse practitioners. We've got a strand of work to look at more closer working with our Scottish Ambulance Service colleagues around how we kind of work together and integrate things, especially when we're looking at remote and rural areas. So we know that there's been quite a bit of work to introduce advanced practitioners into the paramedic world, but we're really conscious that we need to have a joined up approach to make it more sustainable going forward. And that's about considering all of the options available to us.
Sorry, I've got one further question that just popped in as well. There was a pilot programme years ago, they were looking at possibly using the fire service for falls. Has that is that not happening at all now, or will that be reconsidered for the future?
Oh, no, that's a very good question. I'm probably not the best placed person to ask that. Rhiannon, is that something you have knowledge on? Maybe not.
No.
Anyway, we'll find out more information, Muriel, and we'll share it. We'll ask Stephen to circulate it.
That's great. Thanks for that, Jill. It's very relevant that Neil was wanting to come in, but the board is doing a huge amount of work on risk. So the fact that we're developing our own papers on risk is very, very appropriate in terms of what the board's doing, and the board's actually looking at develop things further, and that might be something I think that this meeting can look at, as well as committee can look at as well, and in particular the high risk and the very high risk issues. I think there's maybe a potential to have a bit more detail around them, but these things are kind of iterative, and we're moving in a direction which is similar to where the whole organisation is going. So I think, as Anne said, we could possibly look at some of the out of hours stuff, and that'll just be part of our developing the risk registers as we have them, and the risks that we've got and we know about. So sorry, Neil, you were wanting to come in.
Sure, no, thank you. Regarding sort of OPAL for communities and primary care, the vast majority of primary care doctoring being provided by independent contractors. Is that something that's going to be discussed maybe through GP sub or as the advisory committee structure to the board?
Yeah, you're absolutely right, Neil. So what we have at the moment is the same system that we had reporting all through COVID, where practices, there was a declaration, it was I think 3 levels. So that's the kind of system that we had in place for last winter. So a lot of the intelligence from the primary care managers reported into the daily dashboard around that. And we're certainly not making it or looking to make it any more complex than that process going forward, but anything we do involves GP sub as well.
I mean, I think I can't absolutely speak for them straight away now because it's not been discussed around the table, but I think people would certainly welcome the opportunity to at least illustrate some of the stresses. I know everybody says everybody's feeling stressed, and even more so after COVID, as in stressed on the organisations and the work that we do. So being able to illustrate that would be very useful. And I was just wondering also from the point of view of the risk register, items sort of make their way in or influence and areas influence the risk register always through Datix. So, or do areas such as, and I'm thinking in terms of primary care sustainability and sustainability of practices, you know, with a mind to what's happened just across the way, large practices, you know, going back to the board, etc. So in terms of things like, dare I say it, enhanced services and so on, how do those areas make their way into the risk register?
Yeah, I think Datix is one route, Neil, but I think what happens is that we've got a lot of intelligence where we, in our monthly meetings, it's an open process where people can take things and actually add things onto the register in that dynamic fashion. And I think one of the limitations that we've got in general practices at the moment is that if you're a single-handed GP practice and you hand your contract back, you're only required to give a matter of, you know, weeks, minimum amount of time to hand that back. If it's a partnership, it's up to 6 months, and actually that's not a great length of time. And if we can get to a position whereby, you know, we're kind of aware of the kind of practices that are at risk, it would be really helpful, I think, for the whole system to be aware where we've got practices struggling, whether it's about, you know, workforce capacity or whatever the reason is. But really, really welcome a discussion around that.
Well, thanks very much for that, both Neil and Jill. An interesting discussion about where we're going with risk in terms of dealing with it, recording it, and mitigation. If there are no other questions, I think we're looking to take moderate assurance from that report. So apologies, I couldn't find that there. Are people happy to take a moderate assurance from the report? Yes, we've got some nods and thumbs up. So that then moves us on to any other competent business. And I've only got one piece of business that I would like to add, and that is to thank Michael Simpson, who I believe it's his last meeting as a patient rep, and he's been on the committee since 2017. My short time on the committee, I've seen Michael's contribution, and he's contributes on behalf of those he represents with gusto. So I would just like to say thank you very much, Michael, for your contributions and your involvement in the community, and good luck with what you plan to do next. So I'm sure that.
All right, thank you very much. Thank you very much. Yes, it seems 6 years ago since I had a interview by Maisie Thompson. Yes, it does seem quite a long time. I found it very interesting, very unusual. very similar. When I first arrived, it struck me as very similar with all the acronyms, similar to being in the army. But I got over that, and I'm sure one or two people will be, you know, think, oh, right, he's gone. I can relax a bit more now.
I would hope not. I would hope not.
Right.
You perform a vital function, and you do it well. So you shine a spotlight on areas that need that, and I think you do it politely with good humour. So there's, I think, we welcome your contribution and any addition you have to the committee, and I think you will be missed. You certainly speak every occasion that I've been here, and no, it's welcomed.
Yeah, I've only missed one meeting in 6 years. That was it. Yeah.
Well,
okay, thank you very much.
Good luck for the future, and we will miss you. And on that, do we have Pam?
Yeah, just quickly, I just wanted to, as officer, pass on my thanks to you, Michael. I think it's really good to be in this space. It's good for me bringing papers for assurance. It's good when we have that frame back to us that tests the temperature and keeps us, you know, in check about the work that we're doing and what we're delivering. So on behalf, directly from me and on behalf of my previous chief officers as well, thank you very much for your contribution to the committee. Thank you.
Thank you very much, Pam. Appreciate it. Thank you.
And if there's no other further business, our next meeting is for the 28th of June at 1 p.m. and I shall see the rest of you then. Okay, thanks very much, folks.
Okay.
Bye.
Thank you, Philip.
Bye,
Thanks,
everybody.
everyone.
Bye.
Bye-bye.